Do healing peptides cause cancer? Yes or no? Welcome back to Fitness in Your Mouth. I'm your host, DJ Madsen, and we have a very special guest today. We have Dr. Kristi joining us. We are going to be discussing peptides and potential cancer risk. Dr. Kristi, can you tell us a little bit about yourself and your background?
Yes, happy to be here. So I have my PhD in molecular and cellular oncology, and then I've kind of worked in labs, and then I started working in industry. So I currently sell cancer testing. So we help, it's like a precision medicine program at hospitals where they test cancer patients for putting them on the appropriate treatment.
So, you are also in the fitness space as well, and you work within a lot of these new peptide protocols that we're seeing that are rising in popularity.
That's just a passion of mine. So I've kind of been diving into the research and learning everything about peptides and kind of trying to teach other people to, understand them better so they can make better choices for their own health.
And that's the key word right there was the research in them, not our proven clinical efficacy, because a lot of it right now is still very anecdotal and a lot of it's still being drawn from the bodybuilding industry where we've been kind of abusing these compounds for quite some time. So we've all seen the viral videos and growing concerns with cancer and the use of a lot of these peptides, whether it be a BPC 157 or any of our GHRHs. There was a viral video. Somebody had received packaging where they saw the cancer warnings for the tesamorelin. And then we saw another video come out that just spread like wildfire about how certain providers anticipate an uptick in cancers because of the use of our healing peptides like BPC 157, TB 500. So that's kind of what we're going to dive into today. I guess first and foremost, we can start out with we'll look at BPC, TB, kind of review the mechanism of action behind these and why theoretically there are concerns with this.
Yeah, I do think it has a lot of good healing potential, although it's still only in preclinical models and the animal models. The way I approach these things is yes, there may be some risk, which we'll get into, but they also have a great healing capacity. So if you're suffering from something, then, these are tools that we can utilize. So I just don't recommend staying on them long term because there are some potential risks. So yeah,
So
I did
what do you
use it.
consider long term?
For BPC, my personal, again, we don't have really clear data saying, what the exact timeline is, but generally, if you're not healing an injury in 2 months, I would say that's probably not working for you. Maybe need to seek other treatments. And like in my case, it was gut health issues that I had been suffering for a long time, and it did clear up pretty easily within like a six-week time frame.
Specifically for gut health issues, given the systemic effects of the injectables, did you opt for oral or did you do an injectable BPC so it had more potential to reach other areas that the oral can't?
I did both. I did keep the BPC to a 4-week injection, and then I supplemented with the oral. So I did BPC TB 500 in the morning injection, and then at night I took an oral formulation that was like very specific for the gut. It had all kinds of other goodies in there too. But
So like a BPC, KPV, was it one of those complexes?
exactly.
Have you needed to repeat that protocol at all?
Nope, I haven't. I've been cured from it. So
Okay,
far
that's
so good.
fantastic. With the BPC, the main thing that we're looking at, and then TB500, are how it interacts with growth signaling pathways. And we had discussed a little bit about the VEGF, FGF, EGF. In terms of cancer risk, what are we actually looking at? What are the primary concerns with these? And again, I know a lot of the confusion comes from like causation versus correlation. How do these growth signaling pathways impact that potential?
Yeah, so with BPC, the preclinical models show that it does accelerate angiogenesis, which is what, when you were saying VEGF, that's where the site of injury needs a blood supply, it needs oxygen, nutrients, it does, it's gone. So it'll signal through VEGF to draw those blood vessels, those endothelial cells towards that site of injury. And that's when the healing can occur because we're now delivering oxygen and nutrients to that tissue. So cancer, when we look at it, we have hallmarks of cancer. And one of the things that tumor cells can do is they can also activate these same pathways, because when you think about it, you have one tumor cell that then multiplies and grows and divides and forms this tumor mass. The inside of that tumor mass is also starving from nutrients and oxygen. So one of the mechanisms that it utilizes to continue growing is turning up this VEGF signal or angiogenesis. That's the sort of theoretical concern that we have there. And then with TB500, it's cell migration, angiogenesis, remodeling. That's what we're seeing in animal models. So of course, you can kind of apply that same principle to, well, cancer can do this as well, and it advances the cancer. But I guess the question is whether or not what that actually means too. I mean, number one, if there's no active cancer, there's no issue. We're just using these peptides for healing. If there is cancer and theoretically we can activate these pathways and accelerate it, does that just mean that we detect the cancer earlier? No, I don't know the answer to that, but it's just kind of a question to ask.
A lot of this is theoretical. And one thing we can say for sure is these pathways are not directly causing cancer.
No, absolutely not. And let's be clear, these peptides do not cause cancer. There is no mechanism. They're not
That's the part everybody's waiting for right there.
Yeah. They're not creating DNA damage. They're not activating cancer in any way. It's just that cancer utilizes the same angiogenesis pathway in its own promotion of growth. And that raises so many questions for me as an oncologist, like whether or not that is already happening in those cancer cells, like possibly, like let's just say, for example, you do have an active cancer you don't know about, you start taking BPC 157. Theoretically, yes, okay. If the cancer hasn't already turned on angiogenesis, then you could maybe have that happen a little bit faster in those cells and accelerate that tumor. Maybe that just means you're getting earlier detection. And, that's kind of the theory.
That's one of the things that I've heard a lot is, potentially by expediting, we could possibly have an earlier detection time, which would be ideal. One of the other things that I've heard people talk about is we know that these are modulating angiogenesis, but again, with that lack of data, the known mechanisms of action of certain peptides, do you think we have anything that might potentially help normal, healthy tissue, but doesn't necessarily fuel or ignite malignant tissues at all?
Yeah, yes, to some extent, because it also thrives on inflammation, like that inflammatory state. So when we see certain cancers that are more prevalent in obesity and things like that, so something like, and I'm not giving the stamp of approval because again, this is something that we don't know.
Not medical advice.
Right, not medical advice, but KPV would be an example, or even some of the GLPs that are lowering inflammation and creating a better environment like a healthier environment in the body that could theoretically prevent cancer, So it kind of could go both ways.
You'll have to forgive me. This is way out of my scope. That's why I've got you here now. In terms of cancer progression, I'm looking at basically enhancing blood supply and nutrients to an existing tumor. When we're looking at potential risks, what stage in cancer progression would these become a risk, or is it a risk from immediate formation?
It's a later state. You have certain activating mutations that, like tumor suppressor genes, usually get deleted. So that's what starts the cancer and allows it to grow and evade the checkpoints that we normally have in a cell. But the angiogenesis is, like I said, when it's formed that sort of tumor mass and it's kind of reached that point of like, okay, there's no oxygen in the middle. We're too big now. Like, how do we progress further? And then the tumor starts to spread because it does that through the blood vessels. So
could this potentially be like a pro-repair environment versus like a pro-tumor environment that we're creating, especially with the BPC and TB500s?
Yeah, and when there's no cancer there, and clearly these do have the pro-repair, I don't want people to be so afraid that they don't want to use these if they really need it. Like if you have an acute injury or a gut health issue or something, I think they can be very powerful for that. Like you don't want to get too caught up in these fears that may be irrational to some extent, but at the same time, we also have to take them very seriously because we're putting these things. But the other thing to remember is that BPC, this is a natural peptide that your gut produces naturally, and TB500 is a fragment of a natural peptide. So these are things that are present naturally in our body. And like everything in biology, too much is bad and too little is too bad. We want the middle ground. Like when we get to IGF, we'll talk about that. Or it's like you don't want it on all the time, but it has its time and its place, right? So I think that's where these peptides can be helpful with a time and place that maybe isn't just taking it, 365 days out of the year.
Do you think that that constant regenerative signaling ends up being pathological or excessive that, potentially could have more risk long term outside of the fact that these are research compounds that we don't have extended data on?
That's for me why I would take the cycling approach is just we don't have the data. So for me, it's more of a caution than anything else. I don't know I don't know why we would need to constantly signal if there's no injury, why even drive those pathways, right?
Autoimmune patients that have a higher inflammatory environment. Maybe they're trying to avoid conventional pharmaceuticals because of the side effects. How about low dose long term for those patients?
Something like a KPV, I might still cycle that because the other thing you have to remember is you don't want to suppress inflammation too much because your body needs inflammation. You even know from the weightlifting world, like you need inflammation to trigger that muscle response. You need inflammation for your immune system to work properly. So we don't want to completely suppress it, but in an autoimmune state, that's kind of a different situation where bringing that down would probably bring quality of life up.
Medical providers, specifically ones in this field or in oncology, where are these claims of causation coming from? Do you find that they're rooted in any of our rodent models, or is
I,
it
I mean,
clickbait?
I don't even, yeah, I think that was just somebody, I don't want to speak for them, but I think they were just kind of spouting off without really thinking it through because there's no evidence of it being a causative agent. It's just the acceleration.
Okay. I guess we're looking at protective versus anti-cancer peptides. What are your thoughts on things that we're using like the thymosin alpha, KPV? What are your thoughts on GHKCU?
I think there are thymosin alpha is a wonderful one as well. I think, yeah,
Have you
that's
used
one
that one?
I'm going to.
I
Actually, I have
utilize it in the
my
winter months.
Yeah, that's what I'm planning. I actually have my mom on it because she's going through chemo. So that totally suppresses your immune system. So we're using that to kind of build it back up while she's going through that. Yeah, I think that one could be really powerful and has a lot of good evidence for what it does in the immune.
So not only theoretical, you are utilizing this on your own mother, right?
Yes. Yes. I
Okay.
mean, there are tons of publications on as using it as chemotherapy adjuvant. So it's well reported in the literature.
And they're reducing our pro-inflammatory cytokines, things that can potentially create a negative host environment, essentially.
Yep, exactly. And that's why even the GLPs, there were some recent papers that came out that, of course, these were in diabetics, but they are having lower rates of cancer that the ones that have been on these drugs compared to like people on metformin or something else. So it's clearly creating a more positive environment. And I think it's through the inflammatory response.
But this is my bad because I've never actually read the data on it. When we see the reductions in inflammation with the use of GLPs, is that a direct mechanism that we're seeing, or is that a result of creating a healthier environment within the body because we're losing more adipose tissue?
Reducing adipose tissue is going to be lower inflammation. I think also the insulin sensitivity, basically helping your body to be more insulin sensitive. So there's less glucose in the system, which is also inflammatory. And so is insulin, excess insulin. All of those things are true.
So with the thymosin alpha, we know that it supports immune health. We see T cell activation, and there's a lot of people utilizing it like acute immune support. Like, hey, I'm going on a vacation, I'm traveling, I'm going to be going through international airports. We also see it in autoimmune patients. You're using it on your mom. What about the mechanism of action do you find to be supportive? What arguments do you see to utilize it?
It's going to fall back to balance, right? We don't want to overdo it because the immune system, if you overactivate it, that's not a good thing either. In those cases where it's seasonal once or twice a year, or in a case of like where your immune system is impaired, like chemotherapy, then it makes a lot of sense. It's another one where I wouldn't recommend using it all year round. Short stints of it to help boost your immune system makes sense to me.
We're also seeing a rise in popularity in our growth hormone releasing hormones, growth hormone releasing peptides. We're seeing stacks and actual growth hormone being utilized, whether it's for longevity purposes. We're just trying to restore ideal physiological norms of IGF, and we see them being abused for physique enhancement, where we're kind of moving into super physiological territory. What are your thoughts on the use of these analogs?
It's kind of comes down to balance, which I say all the time. If you're a bodybuilder and you're really just going for that physique, that's something totally different. That's not you obviously know that's not ideal and optimal for health, and you're making that choice. For most people that are thinking about using these, they just want to have a little bit of enhancement. There is a lot of nuance here because we are talking about IGF-1 ultimately. And what I saw when I was scanning the literature is just that it's a Goldilocks effect. So too little is a high risk for cancer and other things, health span wise, like sarcopenia and frailty. But then too much can also drive that cancer risk up, and want to fall somewhere in the middle.
So when you're utilizing a GHRH like with a client, do you follow that standardized cycle that we hear about of 8 to 12 weeks? How do you implement these to reduce these risks?
I think 8 to 12 weeks is a good time frame. It's just good to cycle on and off of these mainly for that reason. Like if you're going to be testing your IGF-1 levels, let me say that these can vary from day to day. You could be doing the same protocol and 3 months later your IGF levels could be looking a little bit different. And I don't think it's that one test that matters. It's like what it looks like if you ideally could test it like every quarter or twice a year. If it keeps going up, that's what we're worried about. It's not that one high value necessarily, but it's that high over time. It's like where it's high year over year.
So when we're looking at IGF-1 and we're looking at cell proliferation potential, what do you think is ideal in terms of blood work ranges? Do you think that there's a significant risk as long as you are staying within physiological norms versus having what would be like our standard baseline when we're aging, we're in our 40s, 50s, 60s?
I did read a couple papers on this, so I can kind of go into exactly what they said. UK Biobank, where they were able to take samples that had been stored and then look at people's risk of cancer later in life. And actually, the one interesting thing that they found was that higher IGF was actually linked to younger people, leaner people, taller, and non-smokers. So essentially, healthier people had the higher levels. And as far as cancer risk, elevated IGF was linked to breast, colorectal, kidney, and thyroid. But then lung cancer and ovarian cancer, and I think liver cancer, those were actually lower in people with high IGF. So that's not clear cut. And then another paper, they saw this twice where there's a U-shaped curve. So low is also associated with high risk, low IGF, and high IGF was also associated with high risk.
So do you pull IGF levels on your clients that are utilizing these analogs while they're actively on them? These are not the same thing as growth hormone where we're very much in control. We're relying on our body's endogenous production. Of course, there's limitations when we don't have a GHRP in place with them, especially if we're utilizing compounds that have reduced efficacy, shorter half-lives, the ones that didn't quite make it to market, like our CJCs versus tesamorelin.
I tend to just be conservative and stick to like the lower dosing ranges. And then, like you said, cycling off. I don't force anyone to do testing, but I do recommend it. That it's not like to be scared if you have one high value, but if you see it every year, it's getting higher and higher, then I think it's time to probably rethink that and come off of it. It could even be indicating that you have a tumor because tumors can elevate IGF as well. So it's like a chicken and the egg. We don't really know which one's causing that. But the key takeaway is you want to be sort of in the middle of the normal, not even on the high end of normal, because that was kind of with the tesamorelin. That was where it was really weird the way they reported it as like 2 standard deviations or 3 standard deviations above normal, which 2 standard deviations just means you're high normal. Theoretically, that could be. And that's where that warning label came up. All it says is avoid if you have active malignancy, which should be common sense. But
It should be. So in terms of overlapping and similar pathways or different pathways, what we see with our healing peptides versus some of these GH analogs, which would you consider higher risk and at what phases?
I would say they're both. If you have an active cancer, I wouldn't say one is better or worse. The IGF is really going to be driving that sort of mTOR pathway, which the longevity people want to keep that always off, right? And bodybuilders want it always on. The truth is, it's somewhere in the middle. We want like ideally half the day it would be on and half the day it would be off, and you'd get a little bit of both. And I think that's what our body prefers too.
Obviously, I have a blood work company. If somebody has this concern, which again, I feel like if somebody's greatly concerned, then maybe don't put research chemicals into your body. What screenings can somebody do? What would you recommend?
So there's nothing that is perfect, first of all, but in terms of finding out if you have cancer, I would first and foremost, any of the yearly screenings that we're, supposed to get, like the colonoscopy, the the mammography, all of those things we should definitely be doing. And I recommend gynecological exams, all of that, because that's going to be our best way to catch it early. With cancer, it's all about getting it early before it spreads. So, and then if you have family history, that's where I would maybe be a little bit more cautious, especially for growth hormone pathways. I would say breast, colorectal, prostate. If you have a family history or if you've done genetic testing and have any risk factors, not to say you can't do it, but I would just be absolutely monitoring IGF very closely on those. And yeah, so I think, that's what I was going to say. So there are 2 screening methods that currently exist. So you can get a full body MRI scan. It's going to look for, and again, it's not 100%. You can get false positives. You could miss
Oh, and they have like
something.
Prenuvo now, right? The full body scan. They use AI to kind of do a screening.
And then there's the multi-cancer early detection, which is a blood test. These are also very expensive. They're like $1,000. I'm going to be doing it this year. And that'll test for 50 cancers, but it's not 100%. And then if you find something, you still have to go to your doctor and get screened to make sure it's a true cancer. I feel like once you hit 50, it's kind of worth doing it maybe every couple years. But I am in this world, so to me, it makes sense.
So if we're playing with peptides that influence IGF-1, we're seeing that increase regardless of which peptides we're utilizing. Like with the BPC, you're saying we're only going to utilize it on an as-needed basis. If you're not seeing improvements in 8 weeks, it's probably not for you. What do you like to see in terms of cycling these analogs?
I mean, I think the 12 weeks on, 12 weeks off makes a lot of sense because you'll get the benefits and then some of that will stay on. It will stay activated to some extent. And then one of the papers I saw where there was still some activity or IGF elevation after 12 weeks, and then around 16 weeks was when it started to really decline. So I think you're still going to get some of the benefits even once you go off of it, and then take a break because that way, like, your IGF can reset. It's never going to be too high. You can, unless you're somebody that has very low levels, and then you could stay on it or do growth hormone itself. But
And
if
that
you're
would be
just
simply at replacement levels, right?
right, exactly.
So we're not seeing any argument for causation based on known mechanism of action. Are there any popular peptides you're seeing where that could be a theoretical risk?
Not yet, although there's one that concerns me, but I truthfully haven't looked into it enough to say yet. But it's that FOXO4 DR1 that scares me because it plays with one of the very well-known cancer pathways, P53. I do want to look into that a bit more. I haven't gotten to it yet, but I would say for now, I'm not going to be using that one.
Personal questions then. What is your favorite peptide you've used?
Oh gosh, I don't know. Right now, I'm really liking SS31, to be honest. I'm kind of
Are
into
you
the
feeling a
mitochondrial.
difference on it?
Yeah, I was having a lot of brain fog and fatigue. I don't know where it came from. And so I decided to try the SS31, and like within a day or two, I was like back online. Like my brain just came back to life. And so I only do it 3 days a week. I did it for like a week and then I thought, okay, I don't think I need to do it every day. So I only do it
Are you
3
looking at it more long term for mitochondrial support, like a 12-week, or are you doing it short duration followed by like NAD plus or MOTS-C?
Yeah, I'm gonna do a shorter duration, I think 6 weeks, and then cycle onto MOTS-C and then kind of see what I go from there. Probably I like Sloop too, but I'm not sure if that's gonna be, I don't know. That one, there's not a lot of data either. So
The dosing is all over the place.
yeah,
Body surface area scaling versus like receptor density and sensitivity. I think we got a long ways to go on that one. But in
for sure.
theory,
Yeah,
exercise mimetics in general, I think especially for limited mobility patients,
right,
could be life changing once
right.
we figure out the dosing.
Yeah.
What peptides do you think have the most practical application for like the average person? Not a bodybuilder, not like our elderly demographics, for like the average person just trying to optimize their health.
It just depends on what your goals are, but I'm really bullish on GLPs right now. Not necessarily high doses where you can't eat, but microdosing. Personally, I've seen in my own self, like my lipid levels have responded really well. My A1C has gone down. It wasn't high, but lower is better no matter what. Inflammation levels. So overall, I just feel like it's such an interesting category.
So you're a lean, fit individual. Have you played with retatrutide at all?
Yeah, not Retta. I haven't done that yet, but I am planning on. I already have it in the stash, but I'm still on trizepatide, so I do like 1 milligram a week just to kind of
So
keep the
very, very low dose
yeah,
then.
yeah,
Are you tracking your own inflammatory markers?
yep. I check all that like 4 times a year.
Did you see any changes with the tirzepatide?
Yeah.
Or were you pretty low
Well,
as a baseline?
I was pretty low as far as CRP. The only thing that dropped was my LDL, triglycerides, and
Triglycerides
yeah,
plummet.
yeah.
What peptide do you use the most with your clients right now?
I guess it depends. I kind of depends on goals. I think a lot of people are interested in the growth hormone peptides more so than and the glow and the clo. Everybody's all about that.
I'm
But
a glow girl. I'm a glow girl through and through. What are your thoughts on Chloe? Because I think for the average person, and when we're looking at cost in comparison to benefit, I feel like that needs to be reserved for like post surgery or an actual injury, whether it's for skin health, skin remodeling benefits, and general inflammation. Do you think something like Chloe is necessary for the average person?
not unless you have inflammation or gut health issues like myself. So I'm a huge fan of KPV because I do tend to, I don't know, it's probably like a perimenopause thing where it's just all of a sudden I have all these histamine issues and gut issues. So yeah, that's really helpful for that.
Have you found that a lot of people have histamine reactions to the GHRHs outside of tesamorelin?
I do. I don't really know anyone else that does. I feel like I'm the only one, but
I thought I
I,
was dying when I took CJC. So
you did. Okay. Yeah. That one,
now
CJC and Sermorelin, I had really bad
with
responses.
sermorelin, I feel like that one's really well tolerated for the most part.
I like Ipamorelin. That one seems to be more gentle for me.
And it doesn't have the same impact on like our prolactin levels. It has a minimal, if any, impact on glucose. I track glucose, A1C. I do like C-peptide, fasting insulin. That's where I like to look at basically glucose handling and disposal with a lot of these peptides, even our mitochondrial support peptides, even MOTS-C. I've seen improvements, and I didn't expect to actually see that reflect in lab work the way that I have.
It's good to hear. Yeah. Because I feel like MOTS-C, people say it either works or it doesn't. It's one of those that it's kind of gets trashed sometimes, but I don't know.
And again, we look at things like SS31 prior to use or in conjunction with as
Yeah.
well. You know, you were talking about how these are potentially going to be viewed as lower risk compounds because they're found naturally. They're naturally occurring gastric proteins, they're derived from our bodies. But of course, this is the exact reason why they can't be patented. They're not novel in structure. We are not going to see any more data on this come out of the United States. What is your best advice for people that are interested in utilizing research peptides, but maybe don't have a formal education in research science or oncology? How can they stay safe outside of hiring you?
I mean, just be cautious. Like, I think the best thing to understand is that everything in biology has a purpose. Like, people hate on cortisol, right? But we need cortisol. We can't get out of bed in the
Well,
morning.
everybody has high cortisol. That's why their faces are
Yeah.
fat. It's not their
Yeah.
body fat percentage, it's the cortisol for
Yeah.
everybody.
But you need cortisol, you just don't want it to be too high. It's just like the same thing with everything in biology. I think it's just using it appropriately, not staying on it for, knowing, I guess, starting with your goal. What is your goal? Not just what is, Joe Schmo over there taking because I saw him on TikTok or, and then all of a sudden you've got 20 peptides that you're injecting every day. So just sticking to your goal and focusing on that and then kind of cycling off, staying smart with it. And there's going to be risk in everything we do to some extent. I mean, like
So you really think moderation is key with these peptides, then
yeah,
that's what it comes down to.
yeah. I mean, you get in a car and drive every day. It's not the safest thing, but we wear a seatbelt. We stop at stop signs. We pay attention to the rules, and it gets us to where we're going. So it has a purpose, and I think that's kind of how I approach peptides as well.
How many individual peptides are we looking at where it's getting excessive? Because I see some of these moms, they're lying out like 30 injections. To me, this is a huge issue because, again, these are research compounds. A lot of it's anecdotal information. You don't have the ability to manage your side effects. We can look at mechanism of action. We can make good judgment calls saying, hey, based on this, we don't know of any, conflicting pathways or contraindications. These should be okay to utilize. And we look at things like if we can combine them in the same syringe, if we're going to see any degradation. But what's your cutoff? Because there's a peptide for everything. The same thing goes with supplements, right? You walk down that supplement aisle. Each one is important, but do you actually need it?
I definitely say if you're starting a new peptide, do that by itself for a few weeks so you really know how it's affecting you and how, you're responding to it before you start stacking and adding things to it. I mean, once you know how they interact, then maybe you can play around with that. But I don't want to say there's a limit, but I think like You don't also, you don't need to be overstimulating like the mitochondrial pathways with five different things. Like maybe one or two is going to be good, and then you cycle off and you try something else because it can overload the process too.
How do you feel about NMN precursors versus direct supplementation of NAD plus, especially in like a healthy young adult demographic, like someone like myself?
I mean, gosh, and NAD is one of those ones that we don't know enough about yet. And I don't know. The precursors, I think there's some evidence that they do get into the cell and they do work. The NAD, even though I do take NAD and I do feel a difference, haven't seen any evidence that it necessarily, even with the injections, is going to get into the cell. But the theory is that it recycles to those precursors anyway, and then you utilize those. So maybe that's what's happening.
I take NAD and I tell everybody this. I only take it because I get sent NAD.
Yeah,
That's why I would probably not invest my own money now if I were 20, 30 years older.
yeah,
If I
yeah.
had a stroke, something like that, then I would probably be looking at direct NAD plus, but I otherwise I'd stick with the NMN precursors personally. I
Yeah.
was wondering what your take was on that.
And then also that, there it is involved in the like the NNMT pathway where that inhibits like the 5 amino. I think that makes a lot of sense too, because if you're just throwing a lot of NAD in there, but you're not able to utilize it because of, this inhibition, then maybe you need both, right?
How do you feel about GHK in comparison to BPC 157 and TB 500?
That one seems a little cleaner to me. I mean, it's not really quite the same pathways. There is some of the remodeling going on, but it also has like that anti-inflammatory impact, turns on like a youthful gene signaling program.
That's probably my favorite peptide.
Is it? Okay, so I use
I
it
use it topically
topically.
and
Yeah,
systemically.
I use it topically. I injected it once and I got this really weird, like, I think it was some type of histamine reaction. So I never did it again, but I actually have a vial that I'm getting ready to open up this weekend because I'm doing a microneedling. So I was like, I'm going to start to
You're
try it.
microneedling?
Yeah.
I just did an Alma CO2 hybrid laser treatment to see how my skin responded because I was actually told that microneedling can be a little bit harder. So to start with this and see how my skin reacted, it was terrifying.
Oh,
But I want
really?
to do microneedling really bad.
I bought my own pen and I've practiced on like the lower intro needles and now I'm kind of ready to the
Get into it.
yeah.
Okay, so do healing peptides cause cancer? Yes or no?
No. They don't cause cancer.
Does growth hormone cause cancer?
I would say no. I think if anything, you know, we don't know that maybe the tumors are increasing IGF, but they definitely utilize that same pathway. Same thing with healing peptides.
Super physiological levels of IGF-1 causation?
Definitely related, definitely correlated to cancer risk, I would say, but I don't know causation. I can't say for sure. With IGF, I think it's a little bit more tricky because we don't know. Long-term IGF is definitely associated with higher rates of cancer.
And is that a
So,
super physiological ranges?
yes,
That's not
yes, yes.
referring to our
Right.
balanced
We're not talking
physiological
about
levels then.
longevity like 1 IU of growth hormone or anything like that. Probably the
And personal take, do you prefer direct growth hormone or do you like utilizing some of these analogs?
personally,
People think growth hormone's very scary, but it's crazy
yeah,
the amount of peptides they'll be injecting
right.
in terms of like our secretagogues and analogs and all the fun things. And I'm like, you're scared of growth hormone, but
Yeah,
this what you're taking hasn't gone beyond rodent data.
exactly.
Still
Yeah.
in vitro, but they're gonna take it.
Right, we have way more data on growth hormone. No, I do use growth hormone. I use 1 IU, so nothing crazy. But yeah, I think for me, it's better just because I do have those histamine responses, so I can't really use a lot of the growth hormone releasing hormones.
Have you've tried tesamorelin?
I have not. I'm kind of afraid of it because of my response to the other CJC.
CJC, we tend to see a lot of histamine responses, even mast cell activation. It can be problematic, and the bigger issue that I see is we might not have a direct histamine response even the first, second, third injection, but 2 to 3 weeks in, when we get those responses, they come in hot and heavy.
Yeah, yeah. It takes a while to build up, I guess. And estrogen, I think fluctuating estrogen plays a huge role too.
And there's still prescribers out there that will take on postmenopausal patients and prescribe solo estrogen completely unopposed as well. That's not something that went away in this wave of HRT popularity.
You've
But I
seen
think
that.
there's a lot less conversation about that now. Now that peptides are kind of sweeping the way, especially on social media, and they're readily available to pretty much everyone.
Yeah. Yeah. And the thing is, if you fix your hormones, I'm sure you know better than I do that that's going to be your baseline. Like everything's going to work better if you're using peptides without having your hormones in check. It's just waste of money to some extent.
I have a lot of women contact me and they are perimenopausal or postmenopausal. They don't like their weight distribution. They are feeling fatigued. They're dealing with some joint pain or even things like vaginal dryness, but they want to take peptides. They're like, "Well, there's a peptide for everything, right?" I'm like, "Well, you're not wrong." But potentially looking at correcting those sex hormones that are causing these issues might be a better long-term approach than running a plethora of research chemicals.
Percent. Yeah. I mean, it's more bang for your buck for sure. And it's well established and well researched. So I couldn't agree more.
So if you have one message for people listening that do have those cancer concerns, what would it be?
I would say it's good that you're cautious. If there's something that you need to use the peptide to heal, I wouldn't be overly afraid. I would do your research. If you do have a family history, then that's where I would probably throw a little bit more caution in there. But they can be very helpful and with healing and things like that. So you just want to be cautious and use them appropriately, not just use them because they're available and you have access to them. Just use them when you need them.
And for someone out there that wants to do their own research, they're interested in the clinical data. Who do they speak to? Because we're seeing misinformation being spread by even industry experts, which I'm hesitant to even use the word expert. I don't like that term, but where would you direct them?
PubMed is going to be where you're going to find your direct papers, and that may be a little bit hard to interpret. We can use AI to help us kind of narrow things down. And I mean, I would still recommend checking because we know that it hallucinates and it's not always right.
It certainly does.
But it can at least point you to some of those papers and sort things out. Because I know sometimes you might search BPC and get 50 pages of results. I am writing a book, so hopefully I'll have that out next year, and that's going to cover all of these topics in detail.
Well, thank you very much for joining us, Dr. Kristi. I will be linking everything for you below in this video. If they are looking for you, where can they find you?
You can find me. My website is kristisawicki.com, and I'm on TikTok and Instagram, Dr. Kristi.
Okay, thank you for joining us.
All right, thank you.